On to
Thank you,
you, sir.
chairpersons, for giving me this opportunity. Organizers for giving me this topic. Can I have the slides, please? Now, the topic that has been given to me is about perioperative fluid strategy, something which we face on a regular basis. Now, in spite of advances in anesthesia as well as surgical techniques, in spite of advanced monitoring that we have today, untoward events in the perioperative period occurs at a rate of about 2 to 3%. This includes development of an acute kidney injury, myocardial infarction, or a stroke. And one of the dominant causes for this is inadequate tissue perfusion occurring either during the immediate perioperative period or in the postoperative period. So one of the main aims during anesthesia and in the intensive care is to maintain an adequate circulating blood volume as well as adequate tissue perfusion. Now, over the years, we have seen that too much of fluids, too little of fluids can both be actually harmful to the patients. And we'll be discussing this in a little more detail during the slides. And the present concept of giving fluids arbitrarily based on certain body weight or type of surgery that we are doing is without basis and not supported by any physiological principles. In the short time that we have, what I will do is look at some of the physiological principles of fluid therapy, type of crystalloids that we use routinely and what are the drawbacks or advantages, the colloids, whether we can still use it or not, then compare liberal versus restrictive versus what is known that has come up recently is the goal-directed fluid therapy. And then I would like to suggest a practical approach on how to manage patients in the perioperative period. Now, whenever we give fluids, two things are very important. It should be based on the fact that there is an inadequate tissue perfusion. And for that inadequate tissue perfusion, we believe that giving fluids is actually useful to the patient. That means patients should have some evidence of fluid responsiveness for which we are giving fluids. And when we give fluids, there should be a response to the fluids that we give. Fluid should be stopped when there is no more indication for giving fluids. And then the question arises, if your patient is still unstable, the question arises whether we should use a vasopressor or a inotrope or an inodilator, which we'll discuss subsequently. Now, coming to the type of fluids that we use, remember that whatever fluids that we use, there is something called the strong ion difference, which is nothing but the difference between the anions and the cations in the fluids that you give. Remember that the strong ion difference in the extracellular fluid that of our body is around between 30 to 40. So whenever we give a fluid which has got a strong ion difference of more than 30 to 40, it means if you give large volumes of fluids, it produces a tendency of alkalosis in the patient. And if the fluid contains a strong ion difference less than that of the extracellular fluid, for example, saline. Saline has got sodium 154, chloride 154, which means the strong ion difference is 0. There's a tendency to produce acidosis in the patient. A general rule of the thumb is that we compare it with the serum bicarbonate level, which is 24. Any fluid which has got a strong ion difference more than 24 produces alkalosis. Any fluid with a strong ion difference less than 24 produces alkalosis in that patient. A few words about the type of fluids that we use. As I said earlier, saline has got a strong ion difference of 0, so they can produce acidosis when we give it in large quantities into the body. Now, the saline is generally considered a slightly hyperosmolar fluid because the combined sodium chloride osmolarity is about 308. But remember, that is one of the most physiological solutions because in vivo osmolarity is only about 285, which is more physiological than most of the other fluids that we use. Coming to the rest of the fluids, including ring lactate, what we call the balanced salt solutions. Most of these have got a bicarbonate donor in the form of lactate, acetate, gluconate, or a malate. And the effects of these has not been studied much, but I'll be discussing a few things. Now, ring lactate has got a strong ion difference of 29, which makes it a very physiological solution to be used. On the other hand, what we use, original plasmolite A, has got a strong ion difference of about 50, which makes it a fluid which can cause alkalosis in patients. But when you actually take up many of the solutions in your practice today, you will not find this, they are not exactly sticking to these strong ion differences. Now, acetate. Acetate was introduced as an alternative to to bicarbonate because bicarbonate was incompatible with both magnesium and calcium salt. Now, recent evidence actually shows that when we use too much of acetate containing solution, it can produce an hemodynamic instability, especially in patients undergoing cardiopulmonary bypass or large volume renal replacement therapy, primarily because it has got a negative inotropic effect and a vasodilatory effect. But the strong point of acetate is that it is extensively metabolized all over the body, unlike lactate, which is metabolized primarily in the liver. So in situations like shock, for example, the lactate may accumulate and produce high lactate levels, whereas acetate does not interfere, gets metabolized much faster. The second important thing is that lactate gets converted into glucose and can produce glycemia, whereas acetate does not interfere with either the glucose levels or the insulin levels in the body. Very little is known about the gluconate part, except for the fact that it is mainly excreted unchanged through the kidneys. And ring lactate is in hypotonic solution. Remember that they have said the osmolarity is around 279, but in vivo osmolarity is 254 or something, which makes it highly, it can be retained in the body as well as produce retained in the body. Now, colloids, much has been said. We have all know about what is known as the endothelial glycocalyx, its intimate relationship with the albumin and how it prevents movement of fluid from the intravascular compartment to the extravascular compartment. Albumin, if you take it per se, has got a lot of advantages, which makes it an ideal colloid to be used in the perioperative period. Unfortunately, there is not a single study till date which has actually shown that using albumin in the perioperative period actually benefits the patient. In fact, I want to quote one study called the ALBIOS trial, which is something that we do every day in our life. We try to maintain the albumin level in the ICU or in the intraoperative period more than 3 grams per cent. This is exactly what they did in the study. They one group of patients, they tried to maintain the albumin levels at 3 grams per cent for the first 28 or 30 days. The other group, they did not bother much about the albumin. And they did not find any difference of mortality at 90 days or 28 days or 90 days. No difference in the organ dysfunction or the ICU or hospital length of stay. In fact, if you go back, as far as albumin is concerned, if you go back in 2004, the SAFE trial was conducted, and in a post hoc analysis, they actually found that when you give albumin to patients with traumatic brain injury, they may actually lead to an increase in the mortality. Coming to starch, now, so much has been, this is one of those fluids that has been maligned so much over the years. It has been criticized because of its ability to produce coagulopathy, kidney failure, bleeding, death, mortality has been increased with the use of starch. Most of the Western countries have actually abandoned it, including our own. We also stopped using it. Now, remember that most of these studies has actually been done in patients who are in the intensive care unit for prolonged periods of time. They have been receiving starch, not in the perioperative period. There are not many studies which has actually looked at the starch use in the perioperative period. One study which was conducted on 160 patients by Juster and colleagues, they used crystalloids versus colloids. The crystalloids was used as a volume therapy in a goal-directed approach, and the primary outcome was post-operative morbidity score. And they found that using starch led to a decrease in the post-operative morbidity score. Not only that, patients who received starch received less fluids, and the net fluid balance was much better in the subgroup of patients. The same authors followed up these patients to find out whether there's any drawbacks of using starch in the perioperative period. At 1 year, they did not find any difference in the kidney injuries, incidence of kidney injury, but the disability-free survival was much better in the starch group. So what I want to say is that forget about what has happened in the critical care. If you look at the perioperative period, using small amounts of starch for short periods of time is not going to be harmful in patients. Now, coming to the various types of fluids that we can use in the perioperative period, saline, as I said earlier, can cause hyperchloremic metabolic acidosis, which, unlike what we thought in the past, is not an innocent finding. It can have its own effects. The support that is given to the balanced salt solution has not been much in the previous years. As you can see, the split study, where it was published in 2015, did not show any difference between the patients who received starch versus those who received, those who received saline versus those who received balanced salt solution. But then the numbers in the study was less, around 2,000 or 3,000 patients. Then two major studies have actually come up called the SMART trial and the SALT ED trial. Huge studies of 15,000 and 13,000 patients each, conducted at 5 different ICUs of a single academic center. And what they found in both the groups, one was the SMART study was in critically ill patients who went to the ICU. The SALT ED was ED trial, patients come to the ED and then went to the wards. And one thing that they found in both the trials was that at 30-day follow-up, the patients who received saline had higher incidence of kidney injury, and the requirements for renal replacement therapy was much higher in this subset of patients. So it more or less seals the fact that using one of these balanced salt solutions is the best approach to the patients in the perioperative period. Now, coming to how do we give fluids, as I said earlier, fluids should be given only when there is a need for fluids, and this is based on the fluid responsiveness. We have various indices of, we all know that we should not be using static indices of fluid status like CVP, pulmonary capillary wedge, where they are out of the window. Dynamic indices like pulse pressure variability, stroke volume variability, plethysmographic waveform variability, all those are in the market now. These same indicators tell us, when we use this, it tells us when you have to give fluids as well as when you can stop giving fluids to these patients. Perhaps the one thing I would like to remind all of you youngsters is that all of us should learn how to use an echocardiography. Because in addition to all the information that you want about fluid responsiveness, fluid adequacy, it gives you a lot of other information. For example, it tells you what is the cause of hypotension in a patient when you're managing the patient. This information cannot be got from any other devices. So echocardiography, all of us should learn. We have also other indices like IVC diameter or SVC diameter, collapsibility index. Remember that whenever you do an echo-based, ultrasound-based technique, it all depends on the view that you get. This is something that we have to remember. A word about pulse pressure variability. It can be used. Remember that pulse pressure variability, if any monitor can support an intra-arterial blood pressure tracing, it will also tell you what is the pulse pressure variability. All monitors have that facility. And this is a very, very simple technique to identify fluid responsiveness in the patient. Remember that there are still gray areas. For example, a PPV of somewhere between 9 to 13% or a stroke volume variability between 12 to 15% or something. There are gray areas. They did not tell you whether the patient is fluid responsive or not, and you have to use other techniques to find out whether the patient is adequately filled or not. And this brings in the picture of what is known as advanced cardiac monitoring, semi-invasive techniques. I'm not going into details of that, but this tells you gives you some additional information in the form of cardiac index or stroke volume variability. And this combined fluid responsiveness along with advanced cardiac monitoring led to what is known as a goal-directed therapy for the perioperative period. Now, liberal versus restrictive intraoperative fluid therapy. Over the years, we have been using so much of fluids for these patients that people have started realizing the disadvantages of giving too much of fluids to the patient. Then came the era of ERAS started coming up, and less fluids were being used in these patients. And terms like restrictive fluid therapy and what is known as the zero balance fluid therapy actually came up because people started using less and less of fluids. And now this stimulated a study called the RELIEF trial, a large study of 3,000 patients where the liberal was considered compared with zero restrictive fluid therapy. The liberal group received about 6 liters of fluids over 3.5 hours, and then with a net body gain weight of 1.6 kgs, versus a restrictive group where they received 3.7 liters and the body weight gain of 0.3 kgs at the end of surgery. There was no difference in the disability-free survival, but patients who received a restrictive fluid therapy had an increased instance of acute kidney injury and requirements for renal replacement therapy. Now, this clearly shows that when you give large amounts of fluids or 2 liter fluids, both have got their own problems. So that came up with the concept of goal-directed therapy. Now, what is goal-directed therapy? Goal-directed therapy is give fluids based on the fluid responsiveness. Stop giving fluids when their patients are not fluid responsive. Look at two other things, the cardiac index and the stroke volume. Keep the cardiac index about 2.5 liters or the stroke volume over 35 ml per meter square. How to do it, I'll tell you in the next few slides. So based on this, two major studies were conducted. The optimized trial, large study of 734 patients. They used a goal-directed therapy in which the cardiac index and the stroke volume was targeted using, the fluid therapy was given using either colloids or the usual group received only crystalloids. There was a trend towards lower mortality in the GDT group. The same study had a meta-analysis of 38 other studies, including the patients of this optimized trial, and they found that there's a trend towards lower hospital mortality in the group that received the goal-directed therapy. Then came the Fedora trial of smaller trial. Here they targeted the cardiac index and the stroke volume using an esophageal Doppler, and they found for the first time that using goal-directed therapy was associated with the reduction in the complications in the GDT group. And these patients who were in the goal-directed therapy had less incidence of pulmonary edema, low incidence of ARDS, wound infections, as well as length of stay in the ICU. So, to come to the last part of my talk, now let us see how do we approach a patient in a setup where you have everything and a setup where you don't have too much of facilities. The anesthesiologist, before going in for a patient, should have a plan for each surgical patient based on the patient's age, comorbidities, the surgical procedure that you are planning, and most importantly, the expertise of the anesthesiologist. Remember that having advanced monitoring does not improve the outcome by itself. It is the ability of the anesthesiologist to extract the data from the monitors and modify your plan, which is going to result in an ultimate improvement in the patient. Remember one more thing. Maintenance fluid, the concept of third space loss, bringing a patient dehydrated to the theater is out of the window. You don't accept that at all. All patients receive a maintenance fluid of only 1 to 2 ml per kg, irrespective of the type of surgery. The remaining that you give is the replacement of the volume therapy. Now, there is no consensus on the type of fluid that can be used for volume therapy. You can use crystalloids. Remember that Starling's principle has been changed. If your patient is hypervolemic, irrespective of whether you give crystalloids or colloids, it will remain in the intravascular compartment, although you may have to give a slightly more amount of crystalloids than colloids. Colloids may be used in goal-directed therapy if you are following that. Probably my own opinion would be don't stick on to one or the other. Use a combination of crystalloids and colloids to maintain your target your patient. Now, fluid responsiveness should be combined. It should be used. PPV can be used in all patients on invasive artery lines. You can, if you have an advanced cardiac monitor, the stroke volume variability, the IVC index or the SVC index may be used. And if you're using a goal-directed therapy, use advanced monitoring. And echocardiography, if you have, it's all very good for the patient. Now, liberal versus restrictive fluid therapy, no. We can't follow either of these things. Don't give too much of fluids. Don't give too little of fluids. As I said, they both have been shown to have evidence of drawbacks. Goal-directed therapy is what is proposed now for major abdominal or major surgery that is occurring in these patients. And how do you do it? The first thing is fill up the patient if the patient has got a fluid responsiveness. Look at the first column. The PPV should be more than less than 10%. If your patient is having a PPV of say more than 15 or 13%, give fluids to the patient. Stop giving fluids when the patients are no longer fluid responsive. Once you adequately fill the patient, then look at two things: cardiac index and the stroke volume index. If your cardiac index and stroke volume index is adequately the same, but your mean arterial, come to the fourth column, if your mean arterial pressure is less than 65, in spite of having a good cardiac index, then you need a vasopressor. This is how you go forward. If your cardiac index and stroke volume is high, your mean arterial pressure is also high, but your tissue perfusion is inadequate. What is tissue perfusion? You can look at the capillary refill time. You can look at the simultaneous sampling of arterial and the venous blood, central line blood. The CO2 difference is more than 8 millimeters of mercury. Then what you need is a drug which perfuses the tissues, like an ionodilator, like for example milrinone or a dobutamine is what is the drug you use. If your cardiac index is mean arterial pressure is more than 65, your cardiac index is low, give inotrope, it will stimulate the heart. Now, this is done regularly during the intraoperative period. You're targeting both the cardiac index and the fluid responsiveness all the time. On the other hand, if you are in a place where you don't have advanced cardiac monitoring, what else can you do? Now, in these situations, if, as I said earlier, you put an arterial line, look at the pulse pressure variability, give fluids according to the pulse pressure variability, and then do two things. One, patients are no longer, just give me 2 minutes more. If your patient has got a mean arterial pressure of more than 65 millimeters of mercury, you have to decide whether you have adequate tissue perfusion or not. If you have inadequate tissue perfusion, you use a drug which will dilate the peripheries like dobutamine. That is the best thing you can use. If you feel that patient's cardiac output is inadequate, CP is going up, then an inotrope is the best drug that can stimulate the cardiac output. So the other thing that, as I said earlier, too little, too much, both are harmful. What is the present concept? The present concept is that you give somewhere between. That means most of the major surgeries, if at the end of your major surgery, you have a patient who is just positive by 1 to 2 liters, then that is the best situation that you can achieve in the post-operative, for the post-operative care. So in summary, fluid should be based on the patient factors, comorbidities, and surgical risk. Balanced salt solution is preferred to normal saline during the perioperative period. Dynamic indices should be used. Any monitor can have dynamic indices now. Fluid challenges should be given only when the patients are fluid sensitive. Goal-directed therapy is what is actually recommended. If you don't have it, go clinically with the fluid responsiveness therapy. And a moderately liberal approach with the positive fluid balance of 1 to 2 liters at the end of a major surgery is the best that you can achieve in a clinical situation. Thank you.
Thank you for that wonderful session, sir. As always, he has pointed out that it's not a one solution for all patients, and that we have to be thoughtful about the patient and the type of surgery to decide on the fluid management. Do you want to add something? Any questions from the audience? Lakshmi madam.
A very nice lecture, Dr. Estein. Just the thing about, you said SVV, PPV can be read off any arterial line. I think the newer monitors have it. Space Labs does not give that. And second is, with so many of the major surgeries turning laparoscopic, the utility of SVV, PPV becomes limited, right? So you really can't rely on that. And if you really want to spend 10,000 to use a monitor that looks at other variables like cardiac output or something, then you really need to know if it's worth it. And even in that study by Niles, which they said there was a higher incidence of acute kidney injury in a restrictive group, I think there was not enough emphasis when the urine output came low in that particular restrictive group of patients. So if we did pay attention to both MAP as well as urine output, I'm sure if even using a restrictive strategy, we are unlikely to get AKI, which is what you and I must have been practicing in our patients.
See, I agree with you with the first part of your argument that especially when you do laparoscopic procedures, there is no thing. But then there are so much of literature that is available that intraoperative urine output is not an indicator of perioperative renal status. Because two things. One is you are raising the intraabdominal pressure, one reason, but more importantly, there's a release of ADH. So based on this, nowadays they say don't look at the intraoperative urine unless the patient is oliguric. Unless the patient is oliguric, don't look at the intraoperative urine output. It's a misleading guide to what is actually happening in the kidneys. I agree with most of the laparoscopic procedures coming in. It's very difficult to go by the SVV. And like I said, these things are useful only with fixed conditions like paralyzed patient, 8 ml per kg tile volume. So many ifs and buts are there. But then if you don't look at it, the problem is you don't have anything at your hand.
Thank you.
Any other questions? Sir, can I ask you a question?
Yes, ma'am. In drop, that is why I keep telling everybody that you have to learn How to use?
Aortic flow velocity is one of the best.
Pardon me?
Aortic flow velocity.
Yes, yes. You
That
can
is
use
one
it.
of the best indicators of dynamic fluid and
VTI of the aorta. aortic
yes,
flow.
VTI, yes.
So one of the take-home messages I would like to tell all the postgraduates is that learn how to do an echocardiography at the bedside. Very, very important for you. Yes.
So, sir, my question is related to echocardiography. You have mentioned that if in case of a hypertension, it's always better to identify the cause, as if there is vasodilatation or if the patient is fluid responsive, or if it is a cardiac problem, you can diagnose by echocardiography. So my question is, in case we don't have access to echocardiography, or if you are not very skilled in using an echocardiography, just with the use of an arterial line, we can see if the patient is having vasodilatation, or with PPV, we can know if the patient is fluid responsive. So if these two parameters are normal, can we assume it is a cardiac cause and give inotropes?
See, I always keep telling my postgraduate that when you have an arterial tracing, there are 7 or 8 important qualitative findings in your arterial tracing. One of which is the upstroke of the arterial tracing. And that's a very good sensitive indicator of the myocardial contractility. If it is a slope is going up going slowly, it means the myocardial contractility is less and you can use an inotrope. But it is qualitative. Second, the area under the stroke volume up to the dicrotic notch, very, very sensitive indicator of stroke volume. Many times in my ICU, I tell my patient, this patient has no stroke volume, give him fluids. The wider the area under the upstroke up to the dicrotic notch is an indicator of stroke volume. If it is too narrow, you'll find very times it means that the patient is having a very low stroke volume. You can give fluids. And of course, the dicrotic notch position, if it is too low, it means the SVR is low. You can give a vasopressor. So a lot of information you can gain from arterial tracing itself. But remember that all this is qualitative and not, you can't quantify that, how much it is.
Thank you, sir. If there are no other questions, can we wind up the session, sir? Thank you, sir. Thank you so much for that wonderful session.